Hello, everyone, and welcome. Thank you for joining us for today's presentation, The Role of Doulas at End of Life, presented by Compassion and Choices and hosted by the American Society on Aging. We will begin shortly, but before we do, a few housekeeping notes. I would like to direct you to the left side of your screen where you will see 5 tabs labeled Speaker Bio, Important Information on Group Viewing, CE Application Here, FAQ/Troubleshoot, Event Resources. The slides for today's presentation are available for download under the tab labeled Event Resources. You will find information on how to claim CE credits for this event under the CE Application Here tab, including links to the application and to the step-by-step CE guidance webpage. Please take the time to review the guide before submitting an application. You will be able to access the CE application a minimum of 2 hours after viewing the webinar, once attendance is received and recorded, although it may take a little longer, so we appreciate your patience. Please be aware that your time is logged, and you must view the entire hour-long webinar to be eligible for CE credit and access the application. If you are not logged into the webinar directly using the email address you registered with, then you will not be eligible for CE credit as we have no way of tracking your online attendance. Follow-up emails are sent by the end of the live event business day that will direct you on how to claim CEs and include links to today's slides and recording. You have 60 days from the live event date to complete a continuing education application. If you have any questions during today's presentation regarding the webinar, you can send those to us at any time using the Ask a Question box, and we will do our best to get to those questions in the last few minutes of today's programming. And now, I would like to welcome our presenter. Kris Kington-Barker is Director of Outreach and Care Provider Programs and an educator in INELDA. Previously, she served for 10 years as Executive Director for Hospice of San Luis Obispo County. Prior to her focus on end-of-life care, Kington-Barker's career ranged from psychiatric nursing to hospital and rural health clinic administration and operations. She serves on the board of directors for Joshua's House Volunteer Hospice, dedicated to serving terminally ill persons who are experiencing homelessness, and she is assisting in establishing end-of-life doulas as core members of their care team. Kris, we are so excited to have you here with us today and to be discussing this topic.
Thank you so much. I really appreciate being here. And good morning to everyone. I want to begin today by setting a little foundation for my presentation about the role of doulas at the end of life. According to the U.S. Census Bureau, by 2030, 20% of U.S. population will be of retirement age. And by 2034, seniors will outnumber children for the first time in U.S. history. That is a stunning realization. In 2020, COVID pulled back the curtain on a number of previously existing and largely unaddressed crises in our healthcare system. We've known for years that we are nowhere near the kind of workforce and healthcare workforce in particular that we're going to need as what I just recounted statistically is going to happen. We also found, as we've known for years, that the death rate was higher in Black and Brown communities because of access, fear, and other factors, including those recognized as racism and unconscious bias. And also, the retirement and aging of an entire generation, the baby boomers, is at the center of the current healthcare workforce shortage, especially in rural communities. These are the people that have been relied upon for healthcare for decades, and they're now becoming the people that are going to be relying upon healthcare for the future. Some of the trends that we know we've seen continuing or when surveyed, 7 in 10 Americans say they prefer to die at home. The reality is that that's not what's happening. The New England Journal of Medicine reported in 2019 that 60% of patients still die in hospitals and nursing homes. And the numbers increased during 20 and 21 when COVID hit. While the availability of hospices has grown significantly over the past decade, we still find that the majority of rural communities have limited access where people may desire to die at home. Many still end up in emergency rooms and hospitals in their final days and hours. Patients and families who choose or get referred to hospice without prior experience of services may find that their expectations are unmatched. And an example of that is the quote here from Linda. I thought when my dad was admitted to hospice, Mom would finally have someone to relieve her of the daily caregiving she'd been doing the last 2 years. The reality is that more and more frequently, hospice agencies primarily serve in an advisory role and from a distance. And it's not because they're not great agencies, they don't have a mission, or they don't care. It's that they are overtaxed and sometimes understaffed. Hospice nurses or aides, according to Medicare statistics, average 45 to 70 minutes twice a week in a patient's home. So who's providing the care for these people when hospice staff can't be there? One of the things that we're seeing more and more frequently in care is that Alzheimer's, dementias, and Parkinson's continue to remain the largest group of primary diagnoses for Medicare hospice beneficiaries. That's across the board, according to Medicare. Couple that with the fact that in 2020, the AARP study demonstrated the number of millions of US adults who were caregivers for someone over the age of 18, almost 48 million. Of those folks, 24% of those caregivers are carrying not for one, but 2 or more recipients over the age of 18. And why? They're forced because of the aging baby boomers. They may have not 1, but 2 parents to care for. They may have a grandparent and a parent on top of children that they may be caring for. The workforce shortages that I just named, limited financial resources, insurances that don't pay for paid caregiving, limited financial resources that don't insure completely for the kinds of conditions like Alzheimer's and different dementias, for hospitalization. And more, we're finding that people are self-identifying that the activities that they're doing are actually activities of caregiving. Yes, they're doing that because they love their families, and it's something that's part of what families do. They care for one another, but it is still caregiving, and it's still taxing. So most people are choosing that they want to die at home. But how do they do that? Hospice censuses are climbing, even though they're not available to everybody, because they don't exist in all places. Much more frequently, they are existing and competing in larger communities and not so available in smaller rural communities. With the large caseloads, it means less time available for the specialization available to patients, for the licensed staff to be with a patient, spend time with the patient, and hear the patient. Shortages in experienced hospital healthcare workers. COVID had a real impact on all healthcare systems, including hospice care. We're finding that in some communities, hospice workers, nursing staff, the caregiving staff are less experienced than they were in years past. Sometimes nurses right out of nursing school are being hired by hospices. Still good nurses, but not as experienced as they were in days in the past. Less time for social workers to spend with their patients. Less time for the nurses to spend on each visit. And it takes a toll on the staff for the hospice and continues to increase the anxiety of the patients and their caregiving family. So when we talk about what is an end-of-life doula, one of the things that doula is often recognized is a birth doula. A birth doula comes out of the late 60s, early 70s here in the US, wherein it was associated with a non-medical person who was educated in the birthing process, who served as an educator and a liaison for the pregnant woman and their family, who provided holistic services to them during education before birth, during birth, and after birth. An end-of-life doula is the same kind of process and person that's available for folks at the end of life. An end-of-life doula, or a death doula, as some people are referred to, is a non-medical person. Now, it may be that some of the end-of-life doulas are formerly or continue to be nurses, social workers, people who are licensed. However, when they're working within the scope of practice of an end-of-life doula, they're serving as a non-medical support person, and they're staying in that lane. They're educated in the dying process, not only in what the physical changes of dying are, but what the emotional changes for the person who is dying and for those who love them. How it impacts the family from time of diagnosis through the process of debility and losing function and having changes to finances, to family engagements, to interactions with friends and outside, to functionality, to future hopes and dreams, to what happens with the family as they try to communicate or don't communicate. An end-of-life doula is a liaison for the patient and the family. Sometimes someone to help with the communication between the physicians or the medical providers. Someone to help with communication between the family themselves. And sometimes just to hear the person who's at the center of all of this, who's the person who is in there dying, who may have the inability to have frank discussions with other members around them because they're really conscious of not wanting to put extra burden on people that are already distressed about their illness and what's happening. One of the things that we do here in North America in our medical culture is we unfortunately have gotten away from seeing that death and dying are currently part of a very natural process, a natural process that is part of acceptance that death and dying is not always a medical failure. Sometimes it can be, but illness is separated from death. Sometimes death is an event that comes extremely naturally and doesn't have to have a lot of medical intervention and medical support, and can through hospice. And one of the things that I want to address to Sonia right now is that with respect to end-of-life role and collaboration, absolutely hospital staff are not dismissive of any of their patients or what they need. And I really don't mean to imply that that's the case at all. I see hospice workers at all levels as being extremely attentive to their patients with whatever time they have. With regard to providing a range of holistic services, that is the goal of hospice organizations, and has always been since the beginning, of attending to the physical, the emotional, the spiritual, and the practical support of the patient. The ability to do that, however, in the amount of time that different families need that kind of support ranges dramatically. Some families require a continuous or a lot of support, while others are pretty self-sufficient. For some families, when they engage in end-of-life care, especially if they're trying to manage fighting the illness, fighting the disease, and death avoidance through the access to health care for as long as they can, when they finally do get to the point where there is no longer an ability to hold off dying or death, it can be overwhelming to try to engage in supporting their person through the end of life, especially if they haven't had the experience of ever gone through it before. An end-of-life doula can provide support and care before hospice is engaged. End-of-life doulas often can have conversations with people in the planning stages of what their desire is or what their needs are around advanced healthcare directives. What is it that a person is concerned about end of life or about the final part of their life that they need to plan for? What are they not prepared for now? In some cases, end-of-life doulas can only specialize or decide to only specialize in having conversations around what if. And advanced healthcare directives are something that anybody over the age of 18 can really benefit from having. A doula can provide an additional layer of support for patients already on hospice services. And how does that work? Well, hospice may already have volunteers, which is an excellent support. Hospice has social workers, they have music therapy, they have nursing care, they have nurses' aides who can support in a number of different functions, including assistance with bathing. If a family needs emotional support or continued support in between those times or additional hours, it's possible that an end-of-life doula could also provide that extra interaction. Emotional support, education, and direction to the appropriate resources for patients and family and caregivers. Doulas do not replace anybody in a medical team whatsoever. They don't replace a nurse. They don't replace a social worker. They don't replace an aide. They're an augment to those services. And when they're working within a hospice team, they work within the team model to support the directions of the team and support and aid in the assistance of team. They can assist in the advanced care planning. They can assist in identifying some of the anticipatory grief and support some of the grieving that is happening during the transitions of dying before the bereavement team takes over after death has occurred. They provide an active presence with people who are informed about dying and death and provide a calming person to be available to the family and to the patient, often including setting through emotional support through the vigil or through the act of dying. Every person who is interactive with a doula is seen as a person who is individually needing support in their own way. So there is no scripted approach to all patients. When a doula engages with a patient or with a client, it's from the process of who are they, what do they need. It's attentive to what kind of family system they're coming from, who their support care providers are, what's important to them, what kinds of additional support outside of the family that they need, how they like to be addressed, who they want to engage with through the family, how they want the family to be supported. And the difference between a licensed care team and an end-of-life doula, the licensed care team creates a hospice plan of care, and they adjust that care plan as the patient progresses through hospice. An end-of-life doula aids in assisting the patient and the family with the plan of care. It's the plan of care that is developed by the hospice team if the patient is on hospice. If a patient is not yet on hospice, the patient and the doula are the ones that together, and it's driven by the patient and the family in terms of what their needs are in the moment and how they want to have their support and where they want to put their attention. Licensed care teams are supported through Medicare and insurance benefits. With end-of-life doulas, the question that we often get is, are they paid by insurance? And they are not. Often, end-of-life doulas will work as pro bono. They may have a sliding scale. They may work as volunteers through agencies. They may work through agencies of staff, or they may work as private pay. Licensed care teams have licensed roles with very clear responsibilities in those licensed roles, with requirements for documentation, for how they have to perform, what's required of them. In end-of-life doulas, at the current time, there are no national board regulations. There are, however, expectations that the doulas have some form of training, and I'll talk more about that in a few minutes. The licensed care team, the care is defined by the state, and by the federal government through CMS. With end-of-life doulas, their skill sets may vary with their training. And it's really important to know what skill set is needed for the patient and where the training is from. With licensed teams, they provide clinical care, and end-of-life doulas do not. They provide non-medical practical care in all realms. They are not medical providers. Licensed care teams have somewhat limited time to spend with patients and caregivers. The end-of-life doulas can focus on spending more time with the patients and caregivers depending on what the determination is by the patient, the family, and the end-of-life doula. Rather than shorter visits, they can have longer visits or prolonged visits or more frequent visits in between visits of clinical staff. They are not 24-hour caregivers. They do not replace home caregivers, but they do provide more focus on spending time with the patient. In different trainings, there are a number of different organizations, more and more all the time, that are training doulas. And they range from having 70 to 90 hours to 40 hours. And the average is about 40 hours of training for end-of-life doulas. That is just the beginning. What really matters with end-of-life doulas is also their experience. Just being trained as an end-of-life doula does not prepare someone necessarily for being an end-of-life doula. I will also say, however, that as a caveat, that it's really important to note that doulas, the work of sitting bedside with folks, the work of supporting people in their dying has been going on as long as people have been living and dying. It has been done and is done in all countries in many different ways, and is done as part of a natural event with all kinds of different names other than doula for as long as we've existed. This is one approach. And what we have found is as we have gotten more and more concerned and frightened about death occurring and more reliant on others to take care of our own person, we become less able and less familiar with how to take care of our own when the end of life comes. We become more frightened. We've become more adverse to what dying looks like, more adverse to thinking that it's going to be something horrible that only a really specialized, trained person can take care of, when in fact, being a person who's concerned and loving and there for the person is actually what is necessary a lot of the time. In INELDA's doula training, as an example, we have 25 hours of live training, 12 hours of 12 to 18 hours, depending on how long it takes, of on-demand pre-work, 2 hours of post-work. Our live training is led by an instructor using multimedia material. We use small group exercises and paired exercises to experience and practice doula skills. And there is no national certification for doulas currently. There is a certificate of completion that doulas receive when they've gone through a training. If there is a certification that is awarded, a certification is specific to the organization that gives it. It is not a national certification. One of the questions that is that, please speak to the relatively new phenomenon of large for-profit companies taking over hospice services. Oh, I can answer that later. Thank you. Some of the topics that end-of-life doulas are typically trained in are in a model of care, applied ethics, a code of ethics, scope of practice for doulas, how they need to remain in their own lane, listening and response techniques, signs and symptoms of dying, and the physical changes that take place months out from active dying through imminent dying and last breaths. Common issues that occur for individuals who are dying, but also for families. Culture and intersectionality, and how important it is to look at each person uniquely through their own culture and intersectionality, and to approach each person from a clean slate, how to engage in our own biases, and how to approach people from a place of suspending those and looking at that own person from what their needs are and how to meet them and what their needs are rather than what we want for their dying or their death. How to assist families in planning and how to look at what's important for them in planning for their end of life and where the resources are if they haven't already accessed them. Vigil guidance and support, what's important during vigil, how to engage in natural rituals and ceremonies or those that are desired by the family. Guided imagery as a tool for reduction in anxiety, increase in control, reduction in pain, as a non-medical technique to assist and support the medical model. Reprocessing the dying journey for individuals who are the caregivers. Something that we found is extremely helpful is to be able to talk about what occurred during a vigil after the family has had time to take care of the natural business and the activity that occurs after death, and to reprocess and to hear back from the doula who was present during the vigil from their perspective of what occurred, the moments that they may not have noticed because they were really involved in the thought of losing their person, the idea that they were just really frightened and really in shock. But to hear back from a person who could see from the outside how really special there were moments for their person. Early grief support that happens during the process of the relationship with anticipatory grief. And this is grief support. This is not grief therapy. Even if a doula is a therapist, they stay in the lane of grief support and allow and stay out of the lane that bereavement support enters into, whether it's a bereavement counselor or affiliated through a hospice as the bereavement team. Teaching self-awareness and self-care, self-awareness of things like biases, self-awareness of how to stay out of having expectations of someone in their dying, and how to allow them to examine their own way into what is it that they want for their death, what is it that they expect, what is it that they don't want, or who they don't want around them. Resources and identification and referrals, making sure that the person has the resources that they need after the death has occurred, whether it's a fiduciary, that would be somebody to help them with the finances, or because that's not the lane that the doula is in, or whether it's someone to assist with filling out paperwork or understanding the insurance forms. Each doula plan of care is tailored to what the person wants. Conversations and time for listening. So I would absolutely 80% of what a doula approach is and what a doula does is conversation and time for listening. And it's about the listening rather than the telling. The doula's role is really to hear and to speak less. It's an opportunity for the person who is in their dying to do their own self-reflection. And the conversation and the tools that we teach the doula for conversation are how to approach conversation from a standpoint of not giving advice, offering opinions, but engaging in conversation to invite someone to share what they have to say and to answer their own questions in the process. Vigil planning, having someone actually think about how they would want their final days to be. Have someone even consider that after years of not feeling as though they have any control over their life and over their illness, to actually feel as though they could plan something still and make some decisions. Maybe make some decisions about where they want to be when they die. Maybe they want to go back in the hospital. Maybe they want to be in another place. Maybe they want to be outside. To have somebody consider what they want for interacting non-medically with their anxiety and pain reduction, and their intention to actually be able to utilize themselves and their body to be able to control some of that, in addition to their medication, if they choose their medication. Attention to the spiritual, not to take over the spiritual or take that away from a spiritual advisor, but to be able to invite someone to examine that and to be able to make a referral to a chaplain, if appropriate, if someone is expressing or exhibiting that there is spiritual pain that they're exhibiting and they want more discussion in that area. Presence during transitions, to be there when families are experiencing changes in the physicality of the person. Not just to be able to tell them what's going to happen, but to be able to be present when those physical changes happen, and to be able to say, we talked about this, or you were told about this by the nurse. This is what you're seeing now. To be able to bring the calm and to be able to bring the caring and the presence of saying, no, this is okay. You're okay. You can be here and they're okay too. after death care, ritual and ceremony. Some doulas also attend to funeral, at home funeral with specific training. Ceremony or memorial ceremonies may be a part of their care. So ways that clients benefit from a doula may be increased satisfaction of care, even with the hospices, with the palliative care organizations, with the home health, or just with what is occurring. They get a perceived attention to an increased intention in their needs, a decreased sense of isolation, that they're not just on the phone. They're actually someone can come and be present. Increased emotional support. There can be improved continuity of care if the doula is working as a team member with a team, or improved continuity of communication with the care team. The patient's sense of control can be enhanced. There's a comforting presence. And there can be an overall decreased fear in the dying process, or being with someone who's dying, or being around someone who's died. Having been with someone who was just so certain that when her mother died, she wouldn't be able to stay in the house with her because she was mortally afraid to be in the house with someone who was no longer living, to 2 hours later seeing that same person in bed with her mom after she had died, caressing her and saying how much she loved her and how beautiful she looked, and that she just looked like she was sleeping, was an amazing transition. How can a hospice organization benefit? Well, it can benefit from a reduction in the patient and caregiver stress, especially for those families that are high anxiety. Reinforcement in the education that they're already providing, and being given information when there isn't good patient or caregiver understanding. Bringing information back and letting the nurse know maybe they need more, maybe there's something misunderstood. Fewer triage and after hours of urgent calls, a reduction in ER visits and hospitalizations. When the family panics at 3 o'clock in the morning and doesn't know what to do, an ambulance may be called. If they can call and be calmed down, or someone can just go over after they've made that call to the hospice, that may be helpful. Increased satisfaction with the plan of care. They may feel that it's more comprehensive. Patients and families improve perception of care. And it can improve the staff communication. Where do doulas work? All of these places that are listed are different places that doulas work. In addition to this, what I would have to say is, because this is also brought to you by Compassion and Choices, one of the other areas that some doulas specialize in is medical aid in dying, in those areas where, in states where it is legal. The idea that because someone is making a decision or opting or possibly selecting medical aid in dying does not mean that they don't have the same sequence of events in their life that they go through when they're going through end of life. There's still all of the emotions, there's still all of the engagements of the family, there's still the need to normalize that death. It's not treated any differently. There can still be ritual and celebration and conversations and engagement with care teams, and it can still very much be a normal end of life, as opposed to something that has to be treated differently. So how do you find a doula? You find a doula through, some are employed or volunteer. Some are with organizations. There are hospice organizations that already have doulas as part of their volunteers, or have staff who have been additionally trained as end-of-life doulas. You can hire an end-of-life doula to assist in developing an internal program. If you're in an organization who wants to develop a program, but you don't have the resources to do that. You can locate through an online search of an end-of-life doula. You can put in your state, your city, and put in end-of-life doula. You can go to you can come to INELDA's website, and we have a registry of doulas by states that you can look at. NEDA, which is the National End-of-Life Doula Alliance, also has a vast directory, and they are a wonderful reference for also checking online doula directories. You can ask for references, schedule a consultation. Most doulas do consultations without any charge. Ask where doulas are trained. Find out what kind of experience they have. And references is always a good thing to try and find. Some of the directories that I mentioned are the NEDA Alliance, the Doula Council, INELDA, and there are other training organizations that are listed on NEDA's training directory. You can go to any one of those and look at their trained doulas. You can see what the doulas specialize in, if they have areas of specialty. If they have areas where they have additional skills, you can see some are been nurses, some are social workers, some are sanitologists, some, you know, there are like a wide variety of folks. And I'm going to go ahead and take your questions. So,
thank you so much, Kris, for that presentation. We do have some questions here. And one that's kind of sticking out right now is, are there any issues that may arise when clergy seek to fill the role of a doula?
No, in fact, we have a lot of, we actually have a lot of people that are cross-trained as end-of-life doulas, and they found that what the difference is, this is from feedback from the clergy that we've trained as doulas, is that the listening skills, the conversation skills that they learn through doula training is different than they're used to using in the role of a clergy. And they really appreciate having both sets of skills together. And by that, what the defining difference is that the conversations of a doula are less directive and more invitational to the person, with open-ended questions that allow that person to take the conversation wherever they want to go and to stop wherever they want to stop. And it doesn't answer their questions for them, but allows them to explore the answers for themselves. And it's part of what we teach around meaning work. And the meaning work for a person at the end of life really is about finding what's important to them at that point and really what they need to have answered and what they do not. And what we hear a lot is that having those conversations really opens up a different kind of conversation with people. And it's really been beneficial from the feedback that I get with the clergy that have filled the role of a doula.
Wow, that was
Sometimes a little bit harder to stay on one side of the line and the other, but a great skill to learn.
Yeah, that was an excellent question. I would have never even thought of clergy wanting to do this. So, excellent question. And kind of in that same vein, can therapists take end of life doula training to be a better therapist?
Yeah, and that's really interesting too, because it's the same kind of issue. Doulas, when they're practicing as a doula, they're not giving direction. They're not making decisions for people or directing them. So when I emphasize that, the grief support is support. It's the kind of grief support that one can give when they have knowledge of what grief can do and what grief feels like, but are not a therapist. So even if they are a licensed therapist, they still stay in the lane of understanding that if someone needs a therapist, they need to be referred out. It would be a conflict of interest for a person who is signed on to be a doula to self-refer to themselves as a therapist.
Yeah, that makes sense. And we also have some questions here just on how do you find where there are end-of-life doula trainings to become an end-of-life doula? Is there a directory for that?
Yeah, through the NHPCO organization, they've got about 45 different training organizations that are listed. You also can go and Google end-of-life doula or death doula training organizations. I suggest that you go to the websites, you check them out for what you're looking for in your training and what you're not looking for in your training. Some are more aligned with, say, a medically directed leaning. Others are maybe more aligned with spiritual or after death care. It really is based on what you're looking for.
And another question is, and you kind of touched on this already, but when should someone seek out an end-of-life doula? 'Cause you mentioned, whether they were in hospice or before they were in hospice. So what's kind of that signal, or when would be the appropriate time to start looking for an end-of-life doula?
I'll give you a couple of examples because it's all over the board. During COVID, I got a call from a couple because they got stuck in the community that I live in because of COVID. They were from Washington State. They were here in California, and they couldn't go back to Washington State. They had been working with a doula up in Washington State, had just started working with her to start advanced care planning. Neither one of them was dying, but both of them were in their late 70s, and they felt like as responsible people, they wanted to do that. With COVID, they were even more anxious about the fact that they didn't have advanced care directives, and they wanted to get their ducks in a row. So I met with two people who they'd not been diagnosed with a terminal illness, but they wanted to make sure that they had everything in order in the event that either one got COVID and got extremely ill. That is a role for an end-of-life doula. I had another patient who was just diagnosed with ALS. And even though she was beginning to show symptoms that led to her diagnosis, she probably had 2 years out. And she wanted to engage services of an end-of-life doula so that she could, while she could still talk, so that she could still engage in some of the things, and she wanted support during her decline so that she could have someone that would be able to follow her and assist with the things that she needed assistance with as she went through her decline, understanding that she at some point was going to make a decision to go on medical aid and dying here in California. But she wanted to live as functionally long as she could, because the last thing she wanted to do was die, but she didn't have a choice about that. And so worked with her for almost 2 years before she finally medicated and died as a result. For someone else, I've been called in as a doula by family when they've had a mom who was transitioning and they were fearful. They brought mom home from the hospital because she said she wanted to be home. She was on hospice, but they were both from out of town, and they were afraid that neither one of them knew how to take care of her or what to do. They didn't have the resources to hire full-time nursing care, and they wanted someone to be there off and on to help just give them support. So those are 3 different kinds of instances, and the mom died within 3 days.
Wow. Another question, you kind of touched on this in the beginning, and this will probably have to be our last question because we're running out of time. But how does INELDA doula training work to address disparities in end-of-life care? And you kind of touched on this when you started your presentation.
Say that again. How does what?
How does the INELDA doula training work to address disparities in end-of-life care, due to race or unconscious bias and cultural differences?
Yeah, it's woven into the training about equity at all different levels. So it's not only awareness about bias toward things, toward the most visible, like color or culture, but also the invisible, like hearing. So everything that we train for when we talk about training for end-of-life doulas, we really recognize that the end-of-life doula approach is unique, predominantly unique to a white culture here in the United States. We have instructors who also are from other countries. So, for example, one of our facilitators and one of our educators is from Puerto Rico, but lives in Mexico and works often with other South American countries and with indigenous people in Mexico. What is so for us, some of us here in the United States, is not so for other countries in the world. And so we really lean toward having people learn how to learn about other individuals by asking questions with humble inquiry and finding out what the needs of each individual is rather than coming in with assumption. So whether it's about a spiritual leaning, whether it is about what a person's attitude is about death, whether it's about what they learned dying was or what death was, through their family, through their culture. All of those things can make a vast difference. What someone's attitude is about hospice care and whether or not hospice care is something that is even acceptable. All of that makes a huge difference in end-of-life care. And it's exploring that with people as we get to know them that makes a difference in how we can serve them and support them through end-of-life care.
Well, thank you so much for your time. It really has been such a pleasure having you today, and we want to thank Compassion and Choices for bringing this webinar series to our audience. If you haven't seen the other webinars from Compassion and Choices, you can find those on our website at asaging.org and check out previously recorded webinars on that page from this series and also for upcoming webinars. If you would like to share today's presentation with anyone, CEs are available for a full 60 days. Thank you again so much, Kris. Thank you, Compassion and Choices, and we hope you will all join us again soon and keep this conversation going so people who are not aware of these services can look into it. So thank you again. Have a great day, everyone.
Thank you.